Hi, this is Dr. Bernstein with our December 2021 edition of Dr. Bernstein's Diabetes University. Tonight, before we start answering questions, I have a special subject to cover. In the past month or so, there have been several announcements of cures for diabetes, and I thought it would be appropriate to tell you how to spot a phony cure. We have about 8 different points to cover. First of all, look to see if the announcement of this cure was published in a peer-reviewed journal, or was it a press release, a paid press release, an announcement in a social medium like Facebook, YouTube, etc., as opposed to a peer-reviewed journal. Also, look for demonstration patients. It's common when there's no real cure, as you may see on television with advertisements for drugs, where people come on the video and say, my wife and I have both been cured of dementia because we took this pill. If you see a person as the evidence and the person makes claims, that's sort of questionable because that's instead of real data. Next, you should look for specific data. Were blood sugar measurements given? Was a hemoglobin A1C given? Were averages over many patients given? Time in range. What was the range? Was the range a very wide range that included abnormal blood sugars, etc.? So you need specific data for you to evaluate. Are any diet details given? What sort of diet were the patients put on? Because it is possible to take mild type 2 diabetics, put them on very low carbohydrate diet and claim that you've cured the disease. Prior to the study that's being reported, do you have values for C-peptide, hemoglobin A1C, etc., so that can be compared before and after the so-called cure? Another thing to look for is the party putting out this information a public company or a company that is planning to go public, because frequently an investigator will join a company or form his own company and get investors to support his research, say, and let's say the research is getting nowhere and the investors want to get their money back. So they take the company public, they make an announcement for a cure, and the price of the stock goes up so that the investors can sell the stock and get their money back. So is a public company involved, or is a company, any kind of company involved? Certainly, if it's a company that's filing a public offering, you have to be concerned. Is the procedure for making this cure grossly invasive or costly? Because if it's either, there's a good likelihood that it's not going to be widely available, that it would only be available for those who can afford it or who can go through expensive surgery, etc. Another thing to look at is how will this cure protect the patients from a new immune attack? One kind of cure might say, well, all we did was we gave them a chemical to allow their stem cells to replicate, the stem cells that are inside their bodies already, in the pancreas, like alpha cells. Alpha cells can be converted to beta cells that make insulin. And if we gave them that once and they get another immune attack that hits the beta cells that we just made, we can give them some more of the chemical to convert more alpha cells back to beta cells. So is there a procedure for taking care of future immune attacks? Perhaps the most important thing to look at, do patients have to be immunosuppressed? If that's the case, I wouldn't call it a cure, because you're substituting one disease for another disease. You're substituting immunosuppression for diabetes, which can be treated. I just went through blood sugars with one of my patients, and all of his blood sugars were in the mid-70s to mid-80s. I've been treating him, I think, for about 15 or 20 years, and he's doing great. Diabetes is a treatable disease. If you want to see how to treat it, you get my book, Diabetes Solution. Immunosuppression exposes you to all kinds of infections, and you can't prevent that. If you're deliberately seeking immunosuppression, you've substituted a disease that can be worse than diabetes. Now, people can argue and say, well, immunosuppression is not that bad compared to untreated diabetes. And indeed, many people nowadays with diabetes are being so poorly treated that you might want to consider it untreated. I know of several insurance companies that have refused to pay my patients for insulin because their blood sugars are normal when they're on our insulin regimen. And these patients have normal A1Cs and normal blood sugar profiles, and now the insurers won't pay for insulin. They're saying they're non-diabetic. So there may be situations actually out there of untreated diabetes, and yes, immunosuppression might be better than untreated diabetes. Now we're going to go into our questions. Before I review the answers to questions, I want to remind you that my answers are guesses that I made for the purpose of educating the listener. They may not be the proper answer for a particular patient, simply because I don't have a full history and have not conducted a physical examination, don't know what medications the patient is taking, what diet they're on, et cetera, et cetera. So I'm giving general ideas that give you a rough idea of how I think. And I may be totally wrong when it may come to the individual who's asking the question. First question. Is type 1 diabetes correlated with the following symptoms? Brain fog, feeling spaced out, fatigue, lack of energy, regardless of hours of sleep, inability to concentrate, and lack of motivation. Well, back in the old days, before I was able to measure my own blood sugars, many of these complaints applied to me. my blood sugars, when I finally did measure them, would go from maybe 20 or 30 to 400 or 500 or 600 twice a day. And I was in the state that this person describes. But if you have normal blood sugars, you can't blame it on the diabetes. There could be a host of other diseases, even psychological problems, that can cause these symptoms. Most common would be low thyroid, hypothyroidism. I find that I test every new patient who comes to see me. I don't mean that they're newly diabetic, but they're new to my eyes. Patient comes in, I see him for the first time. I get a lot of lab tests, including free T3 and free T4. And in about 80–85%, maybe more, of these new patients, they're hypothyroid. And some of them are severely hypothyroid. I was hypothyroid when I was in college, and I slept my way through college. So these are all possibilities. But there are many other diseases that can cause these symptoms too. Do you recommend more carbs and more protein for diabetic women who are pregnant or breastfeeding? Well, this person is giving me an either or, and of the pregnant women that I've treated, we've upped the protein to give enough amino acids for the growing fetus, and we've minimized the carbohydrate. I have not raised carbohydrate for pregnant women. In fact, I have treated women who were obese before they became pregnant, and now we have to certainly cut way back on their carbohydrate intake because we don't want them gaining more weight. In fact, I try to get obese people to lose weight during pregnancy. I'm a type 1 diabetic. I checked my 24-month-old child, 28.5 pound baby's sugar. It was 151. She had enough carbs to raise her blood sugar to 500. I checked again in an hour, and it was back down to 70. That's pretty darn good. Could she be diabetic or pre-diabetic? If so, how many carbs should she be limited to, and how often should I be checking her levels? Well, it looks like what happened here is a parallel of a glucose tolerance test. When you give a patient a glucose tolerance test, you give them a glucose solution to drink, you watch the blood sugar go way up, and if in a two-hour period of time it comes back to normal, the guidelines say that the person is not diabetic. So here, this child went up to 151 in spite of a big carbohydrate load, and then came down to 70. It doesn't look threatening to me. Now, there may be other information that I don't know about. The mere fact that the baby is the offspring of a type 1 diabetic, might lead us to say, well, she's pre-diabetic by virtue of that fact, and that every year or so you should check a hemoglobin A1C. I would say that just because she's your child is a good reason for the pediatrician to periodically, maybe once a year, check A1C. You could consult a pediatrician and see what he or she thinks. I am 30 years old and I've had type 1 diabetes for 14 years. I am following your guidelines for the low-carb diet and have seen much success, great success. I consume about 180 grams, or that would be 30 ounces, of protein per day. In your book, you mentioned that 1,000 milligrams of calcium should be consumed for every 60 grams of protein. And then the person asks for details about that. Well, first of all, the book was written in 2011. Actually, it was written 2 years prior, 2009, published in 2011, and the guidelines may have changed since then. So I don't know if there are any treatment guidelines for whether there should be added calcium with protein in the diet. I do not recommend calcium pills. Usually, if you need supplemental calcium, it should be from your diet. So you could get a lot of calcium from cheese, for example. Hard cheese has a considerable amount of calcium in it, and you could look up the calcium content of hard cheeses and consume enough cheese in your meal plan to get additional calcium. There are a number of sites on the internet that give you the nutrient values, the nutrient content of various foods. But you should also look on the internet to see whether there are current guidelines advocating calcium consumption with dietary protein. Last Monday, my 19-year-old daughter went DKA. That's diabetic ketoacidosis. She is learning to take charge, but made a mistake whereby she was ill but being cared for by her boyfriend all day. I did not know until 5 p.m. when he brought her home. Now, the father apparently next goes into great detail about how they sent her to the hospital, and the hospital made her worse, and she had to check herself out, and so on and so forth. And he doesn't ask me any questions. He just gives me a story. And I have some thoughts. My thought is that she should learn how to take care of herself, and therefore she's 19 years old. The whole family should read my book, Diabetes Solution. She should get a continuous glucose monitor and one with an alarm function. Right now, the Dexcom is the only one that will sound an alarm, and she should have followers. That is, individuals who are close to her, like family, and possibly her boyfriend, who can get an alarm on their cell phone whenever her blood sugar is above a certain level or below a certain level that she can set. So all of these would be mandatory, and she certainly should learn how to take care of herself. And anyone who gets an alarm should be in touch with her and assured that she's doing what she's supposed to be doing. My husband has had type 1 diabetes for 19 months. We've read your book once. We follow a virtually zero carb diet. Only eat twice a day, and his last A1C was 4.8. And he was recently diagnosed with both Graves' disease and Hashimoto's thyroiditis. We looked in your book for Graves and found nothing. And she wants to know why I don't discuss Graves' disease in my book. Graves' disease is too much thyroid, and it usually affects the eyes, can cause proliferation of fatty tissue behind the eyes. The eyes frequently seem to bulge, etc. And it's quite rare. Thyroidologists may see a lot of Graves' disease because that's their specialty. But I have not seen one case. I've been in practice since 1984, and I've not seen one case of Graves' disease. And because it's that rare, there's no reason for me to discuss it in my book. There are many other diseases that are relatively rare that there's no need to list in my book, so I don't have it in my books. My A1C right now is 5.4%. I'm trying to see what treatments are needed to lower that even more, and what to eat and not to eat to get better results on my glucose levels. I'm having some issues also with neuropathy and stress. Well, I would suggest you read my book, Diabetes Solution. Stress, by the way, can cause overeating, which in turn can cause higher blood sugars. So if you're experiencing emotional stress, that should probably be dealt with. I don't know specifically what you're doing, so I can't make specific suggestions other than reading my book, Diabetes Solution. Since you're probably a type 2 diabetic, you might want to also look at my book, Diabetes Diet. I'm a type 2 diabetic for 10 years. I'm currently on metformin 1,000 milligrams twice a day and Genuvia 50 milligrams once a day. In spite of following a low carbohydrate, moderate protein diet, along with resistance training, my doc wants, my A1C was 6.8%. So this person has an A1C that's elevated. 6.8 would be somewhere around averaging about 170 milligrams per deciliter, which is more than double normal. My doc wants me to try Trulicity instead of Genuvia. Well, Genuvia is a drug that has very little effect upon hemoglobin A1C. Trulicity is a GLP-1 agonist that you inject once weekly, and my guess is that it would have a relatively small effect upon A1C also, but that's a guess. So you could try to do what the doctor suggests and see what happens. My guess is that it might lower your A1C slightly, but certainly not bring it down to normal, which would be around 5% or below. The chances are you may need some insulin, but let us know if the Trulicity works. I would be surprised, and I'd certainly want to know. I'm interested in private sessions with Dr. Bernstein himself. My name is Eric, 29-year-old diabetic, type 1 diabetic, halfway through the Diabetes Solution book. I have so many questions. I am Swedish and I live in Thailand, so I'd prefer online sessions if the good doctor is available. Please let me know what is possible. Well, first of all, if you read the entire book, you might not have any questions and you might be able to take care of yourself because that was the intention of the book. So I think it's sort of premature to want to seek my help when you haven't even read the whole book. So that's my first suggestion. Number two, if you've really read the first half of the book, you know how to reach me directly because my phone number is in the book for people who want to know what blood sugar meter we're currently recommending. We gave them a way of contacting my office to inquire. So if you really read the first half of the book, you have a phone number for contacting me directly and don't have to do it via this medium. What blood glucose range should I set on my continuous glucose monitor? And what is my blood sugar target for bolus wizard correction for both high and low that I should use? I can focus on a clear target similar to non-diabetic in millimoles per deciliter. Well, he's talking about a bolus wizard correction. That leads me to suspect that that's a term used by an insulin pump manufacturer and that he may be using an insulin pump. So I would suggest, first of all, that you read the book, my book, Diabetes Solution. I have no idea of your medical history and even your age, so it's hard for me to make any suggestions. My book would make suggestions as to what are normal blood sugar readings. I keep seeing that the new treatment, transplanting islet cells, is only done on brittle diabetics. Are some of us brittle? Have you ever had a patient that, despite willingly following your protocol, still experiences severe hypos? I know you require us to wear a continuous glucose monitor. Well, for many years, I've maintained that brittle treatments are more common than brittle diabetics. Usually, doctors who do not know how to treat the disease claim that the reason the blood sugars are so erratic, going very high and very low, is either because the patient is brittle or the patient is non-compliant. And both of these terms are very common in the medical profession. Now, in my experience, many patients are very easy to treat, especially type 2 diabetics who are not overeating. But there are patients with gastroparesis. Remember, if you've had high blood sugars for several years, say maybe 5 years, there's a very good chance that your digestion will be unpredictable. And once you have unpredictable digestion, you have unpredictable blood sugars. And it's very hard to work around this particular problem. I have tricks for treating gastroparesis. They're not perfect solutions, but we do improve things. So gastroparesis can cause a brittle diabetic. Someone who has carbohydrate craving can be a brittle diabetic. Children going through puberty, or even children who are rapidly growing and making a lot of growth hormone, can be brittle diabetics and difficult to treat, but not have the wild swings that most diabetics have who have not read my book, Diabetes Solution. So there are brittle diabetics, but there are also probably a lot more brittle treatments where the practitioners just don't know what they're doing. And of course, nowadays, most physicians, especially endocrinologists, are still following ADA guidelines and recommending high carbohydrate diets, which of course leads to brittle treatment. How to know my basal insulin dose for Lantus. Again, read my book, Diabetes Solution. And you also will find in the book that I point out that there have been studies associating Lantus with increased cancer incidence, and there have been studies going both ways. I think there were 4 studies showing associating it with increased cancer risk, but other studies showing it not so associated. So I stay away from it myself and don't prescribe it for my patients. So I would suggest that maybe you switch to Levemir, and you could read the book for how to work out your dose for Levemir. And basically, it's enough insulin given at the right times of the day so that if you eat nothing all day long, your blood sugar stays normal. That's a definition of a basal insulin. My 8-year-old would like to know the best way to respond to people when their health advice is eat a low-fat diet. Well, what you might do is get hold of a book called A Big Fat Lie, written by Gary Taubes, Taubes. I believe it's still in print, or you could get old copies from Amazon and just flash the cover page to the people who tell you that. And if they want to know why, they could read the book, because the information that you're being given is a big fat lie. Why sometimes during daytime, 1/4 glucose tab raises my type 1 14-year-old son about 20 milligrams per deciliter, and nighttime, while trying to rise from a low, a whole tab, that would be 4 times as much, doesn't do absolutely nothing. Thanks. Well, I could only guess. One guess is that at night he's having a large meal, you're giving him a lot of insulin, and because you're not following the guidelines of my book, Diabetes Solution, some days the insulin is much too much for the meal, and you're trying to get low blood sugars back up, and you're fighting huge doses of insulin and having a losing battle. And maybe earlier in the day, you're having smaller meals and less insulin, and therefore you're not fighting so much extra insulin. That's one possibility. Another possibility is that your son has gastroparesis. And on some nights, the stomach, the hallmark of gastroparesis is unpredictable emptying of the stomach. So one night, your stomach might empty normally, and he requires a substantial amount of insulin, but the next night, his stomach might not empty until 6 or 8 hours later, and now you have all that insulin on board, and you're trying to fight it with glucose tablets, and you're having a losing battle. Another problem with gastroparesis is that it's hard to even digest the tablets. I recommend liquid glucose for most of my patients, certainly the type 1s, and I insist upon liquid glucose for patients with gastroparesis. And the liquid glucose comes in little bottles like this. Is it okay to do an intramuscular shot in the shoulder? My muscles are larger there than further below by the deltoid. So I find it easy to inject up where the muscle is thick at the shoulder. Well, the deltoid extends all the way to the shoulder. And I give most of my intramuscular shots, which are corrective doses. If I'm a little elevated, I might take 1/4 of a unit of Humalog, for example. And I do it right up near the shoulder. That's where the deltoid is. What is the treatment for lipohypertrophy? Lipohypertrophy is something that you see in many insulin pump users, where the pump is injecting insulin at the same site day after day. Now, the pump users tend to switch from right side to left side and vice versa, but put the cannula more or less at the same spot each time they do it. So they're injecting insulin, which is a growth hormone. It's an anabolic hormone, and it promotes the growth of fat. And for many people, it'll cause fatty bumps or even wings to occur at the infusion sites. So how do you reverse this? You stop using a pump. There are many other reasons not to use a pump. I've gone over them in my videos. They're also stated in my book. If you stop using the pump so that you could rotate your injection sites, eventually the fat goes away, but it may take years. By the way, when I was a kid and we did not have human insulin. We had animal insulins, beef and pork insulins. I developed lipoatrophy, where at the injection sites, we lost fatty tissue. So and we were improperly instructed to inject in the sides of our legs, and I had depressions, big dents in my legs from injecting large doses of animal insulin, and it took years for those dents to go away after I wised up on how to use insulin properly, and we got human insulin. How many hours a night on average do you sleep? How many times do you wake up to check blood glucose? Well, I have a condition called BPH, benign prostatic hypertrophy, and I wake up to pee. And sometimes, if I'm getting up to pee, I might as well check anyway. And I think that I average something like 3 times a night to pee. I wear a continuous glucose monitor that will wake me up if I have a high or a low blood sugar. I sometimes get alarms for lows, but my big wake-ups are to avoid. And because of that, I don't get as much sleep as I would like. Sometimes I can fall asleep right away afterward, and sometimes I can't. So my guess is that I get around 6 or 7 hours sleep a night. I wish I got more. I'm a type 1 diabetic patient. In Sweden, the doctor will not give regular insulin, and I can't change the healthcare system. What's the best plan B to reduce the effect of protein rise after a meal? We are using a pump. Well, although I don't recommend pumps, you don't need regular insulin in a pump. If you're using a pump, you want to use a rapid-acting insulin, and if you want to cover a meal with an insulin pump, you just slow the infusion rate. So there's absolutely no reason to use regular insulin, you just slow the rate. Now, are you able to keep your blood sugars normalized with the pump? I doubt it very much. Any thoughts on Afrezza for correction doses? Have you or your patients used Afrezza? I've used it on one patient who is pubescent and also having growth spurts, and periodically will go, I shouldn't say periodically, occasionally will go up very high overnight out of the blue, and we want to get the blood sugar down as rapidly as possible. And Afrezza does work very rapidly, but it's far too potent. It's supplied in, I believe, 4, 8, and 12 unit doses. The doses come as a powder in a little packet. So to try to give a kid a 4-unit packet of Afrezza would rapidly send their blood sugar down to 0. But I had a very cooperative mother who bought a milligram scale, weighed the powder, in a packet of Afrezza and doled out by the way, the Afrezza sold with 30 packets, each of 4 units. She emptied all 30 packets and put 1/10 of a dose or 4/10 of a unit back in each packet, then inserted this packet with 4/10 of a unit into the Afrezza inhaler and gave it to her child. And indeed, it worked. It worked rapidly. It did not send her too low because it was 1/10 of a dose of their lowest dose, but the absorption was unpredictable. Nasal absorption of insulin or oral absorption is not predictable. You could do it on 10 different occasions and you may have weighed out the same amount, but you get 10 different levels of absorption. So it's really an impossible situation for type 1 diabetics. I had a type 2 diabetic who spent his life traveling around the world, his business life, and he was always on airplanes, not able to prepare his meals himself, so he was eating random meals and making random corrections. And although he was able to rapidly get his blood sugars down, he did not have predictable results. What do you think about omega-3 fatty acid substitution in order to get more insulin sensitivity? I don't know if it makes any difference. I doubt that it would, but I have seen blood sugar improvements in type 2 diabetics using alpha lipoic acid with biotin, which is not an omega-3, but this reminds me, the question reminds me of the ALA. It's the right enantiomer of alpha lipoic acid, so we call it R alpha lipoic acid with biotin. And there was a brand called Insulo, INSULOW, I believe, that had the right amount of biotin in the alpha lipoic acid. The straight alpha lipoic acid does deplete the body's biotin stores, so you do need a supplement that contains biotin. And for people who are making their own insulin, type 2 diabetics, it can be helpful. And also type 1 diabetics who are still making some insulin. It makes what little insulin they're making more, in effect, more potent. Now, how successful is this? It's hearsay for me. I'm trying it on a few patients. Maybe in a couple of months, I'll know how successful it is for my own patients. How common is an ailment called EPI, or exocrine pancreatic insufficiency, in type 1 diabetes? Well, I've read one or two peer-reviewed articles describing exocrine pancreatic insufficiency, and I believe one of them claimed that all type 1 diabetics have some degree of this condition. This means that in addition to not making enough insulin, the pancreas does not make enough digestive hormones, such as lipase, or which helps digest fat. There are enzymes that digest carbohydrate, enzymes that digest protein, and the pancreas makes all of these, but apparently it is claimed in the scientific literature that diabetics make less of these digestive enzymes. Now, how do they know this? I don't remember. I did not save the articles that discuss this, so I can't go back and see how do they know that less digestive enzymes are produced. And I could imagine that if they looked at blood sugars after meals, they'd have the problem of how do you distinguish this from gastroparesis, which slows digestive emptying. So I would not know how to figure it out. I can diagnose gastroparesis by doing what's called an RR interval study. So it would be interesting to take some diabetics who don't have gastroparesis and see if we can figure out how well they digest protein and fat. These video broadcasts are put on by a physicist, 2 high school students, and myself. None of us are experts in generating data on the internet. We're playing this game by ear. We're hoping that our message gets out, but we also know that there are at least 30 million diabetics in the USA, many more worldwide, and probably at least double that number of pre-diabetics who could benefit from our education. But we don't know how to increase our distribution. What we're doing is the tip of the iceberg, and we need help. So if there's anyone out there who knows how to do internet distribution and is willing to help us, we are not collecting money. We don't charge for these videos. We're spending our own time and our own money on this. We cannot afford to hire someone. So if there's anyone out there who's grateful for our help with diabetes and who can help us spread the word, we'd certainly appreciate it. You contact us just as if you were asking a question for a video for us to answer. So please, we solicit your help. That's it for our December 2021 Diabetes University. We'll see you next month. Thanks for watching. Have a Happy New Year and good luck.